Hello nursing students, my name is Erin McGuire and I am a D&P student at McKendree University. As a nurse, I have seen firsthand the importance of safety in healthcare setting. I have worked as a nurse and experienced the frustrations that often occur in the hospital setting. As a manager, I have enforced the rules to ensure nurses adhere to the policies to protect the patients under their care. And now, as a nurse educator, I'm responsible for teaching the future generation of nurses like yourselves the basics of nursing care, including safety and medication administration. Healthcare has taken a very hard look at the systems in place and determined that there are too many errors in medication administration. Since the release of To Err is Human in 1999, many healthcare agencies have taken the report to heart and changed policies and procedures for medication administration. Businesses such as the hospital utilize data mining as an effective way to search the database within the organization to gather information on large data sets. This allows the business to predict outcomes and make changes as needed. In the clinical facility in which we attend clinic, barcode scanning is the standard in place to ensure patient safety during medication administration. As your clinic instructor, I pass medications under my name and license. So our healthcare facility actually monitors the barcode verification of every nurse that passes medications in the hospital, including your clinical faculty. So the purpose of this presentation today is to assess the specific data in the electronic healthcare record at Heartland Regional Medical Center. By the end of this presentation, I hope that you will be able to do a few things for me. Some of these things are going to include, we're going to discuss the significance of medication errors in healthcare. I want us to be able to state initiatives taken by healthcare to improve medication errors. We should be able to explain the barcode-assisted medication administration. We're going to discuss how workarounds occur in medication administration. I also would like us to be able to comprehend data presented on barcode-assisted medication administration. And finally, we're going to discuss the factors that could impact this data presented. In 1999, the Institute of Medicine released a report indicating that at least 44,000 and maybe as many as 98,000 people die each year from medication errors that could have been prevented. This landmark report increased the national focus on improvements and the prevention of errors in patient safety. This report increased awareness of the significant risk of medical errors. However, the pace is slow, and there is more work that has to be completed. The outcomes or clinical significance of many medication errors may be minimal, with few or no consequences that adversely affect a patient. In addition, numerous medication errors go unrecognized and are not detected or reported. Tragically, however, some medication errors result in serious patient morbidity or mortality. So therefore, medication errors, including those that we consider close calls, must not be taken lightly, and risk reduction strategies should be established to prevent or mitigate patient harm from medication errors. So one of the most publicized medication errors occurred in 2008 to the twins of Hollywood actor Dennis Quaid. And as some of you may recall, the children received the wrong dose of heparin, and the children spent the first few days of their lives attempting to overcome this medication error. It was at this time when the public became aware that these events were happening in hospitals, even the best ones like Cedars-Sinai. And this was a preventable error, and it occurred because policies and procedures were not followed according to the administrative staff at Cedars-Sinai. So while we're sitting here, I'm going to pose a question to you. So how many of you have seen a policy not followed by the hospital staff while you were at clinical? If you saw it, did you think to yourself, well, it isn't hurting anyone, so I guess it's okay? And if you think that, you're not alone in that thought. But you need to remember that policies and procedures are going to be in place for a reason, and usually safety is going to be that underlying principle. Since the report issued by the Institute of Medicine, technologies have been implemented to reduce these errors in healthcare systems in the United States. Computerized physician order entry and electronic prescribing mitigate errors that occur through misinterpreted physician's orders. Now, I realize some of you probably aren't old enough to remember this, but I distinctly remember the difficulties that were experienced with handwriting interpretation. So now with physician order entry, we don't have those complications anymore. Smart pumps are programmed to double-check dose and infusion rates, and it should warn personnel of unsafe settings. There's also automated dispensing cabinets that have been found to reduce the amount of time that nurses spend administering medication, and it can be useful in reducing errors in administration time and dose omissions. Barcoding systems provide an additional layer of safety barrier when implemented within these dispensing processes. Every time a nurse gives a medication, a complex series of steps has to be performed in order for the medication to be administered safely and correctly. Each step in the process provides opportunities for error because of interruptions, complexity of tasks, not following the rights of medication administration, and using a workaround. Medication errors in hospitals can lead to patient harm, and it's estimated that the national cost of medication errors is $2 billion annually. And we've already discussed that the Institute of Medicine estimates that almost 100,000 people die each year from these mistakes. The majority of medication errors that affect a hospitalized patient occur when the medication is incorrectly administered at the patient's bedside. To help prevent such an error, technology has been developed to verify medications with an electronic medication administration system. The systematic integration of information technology into hospitals has the potential to make important reductions in medication errors. Barcode verification technology is used as a strategy for reducing medication errors. It does so by guiding users through the appropriate medication verification process, recording medication administration data correctly, and alerting the users to potential errors, all while at the patient's bedside. This system ensures that the rights of medication administration are followed. When a nurse scans the patient's armband using a handheld scanning device, the chart opens into the patient's medication administration record, or the MAR. The barcoded med administration software guides the nurse in reviewing the MAR and determines which medications are due for administration. After selecting and preparing the medications for administration, the nurse scans the barcode on the unit dose medication package. If the scanned medication matches the medication on the profile, including the dose, the route, and the time, the nurse completes the verification process and administers the medication. However, if the drug is not on the patient's medication profile, or if the dose is too high or too low, the dosage form is incorrect for the intended route of administration, or the administration time is too early or too late, then an alert is generated to warn the nurse of a potential medication error. Unfortunately, barcode medication administration systems are not always used as intended or instructed, and so-called workarounds can occur. A workaround is a temporary method for achieving a task when the usual or planned method is not working. In IT, a workaround is often used to deal with hardware, programming, or communication problems. A study by Koppel documented 15 types of workarounds associated with barcode med administration systems, such as affixing patient barcode ID wristbands to computer carts and carrying several patients' pre-scanned medications on their carts. The causes listed as reasons for the workarounds also include malfunctioning scanners, unreadable or missing patient ID wristbands, medications without barcodes, failing scanner batteries, and uncertain or unstable wireless connectivity. The issue with workarounds is that if they are frequently used, they may decrease or eliminate the potential benefits of technology. Workarounds are a response to pressures of competing obligations. So, for example, to be efficient yet thorough, or to make flawed systems. Bending the rules to help a patient is ethically problematic. Many nurses use workarounds as a tool for managing daily work. Many nurses respond when questioned about workarounds stating, "Well, we can't do our jobs without them." So when educating staff about the importance of adhering to barcode administration, it's equally important to encourage staff to bring problems forward to correct the process. And this includes you as students in the clinic setting. So if you're finding a process that isn't working, rather than creating a workaround, it's better to bring the problem forward so that people can get together and find a way to make it safe and ethically benefit your patient, as well as not making your job more difficult. When a quality improvement initiative such as barcode medication administration is implemented, it is crucial to run data analysis to determine the effectiveness and compliance of the initiative. At Heartland Regional Medical Center, this process is reviewed monthly by the informaticist. According to the Heartland informaticist, when she performs a system analysis, she obtains two numbers: a percentage of patient armband scans and the percentage of medication labels that are being scanned. To generate the reports, a standard report from the vendor of the electronic medical record, and in this case it's HMS, which is a system of MedHost, it's used to download the data of interest into a comma-separated values file, or a CSV, which is then opened into a commercially available spreadsheet program. Barcode medication administration reports are generated monthly and distributed to nurse managers after being converted into a format compatible with the spreadsheet program. Each unit has their own tab on the spreadsheet for a clearer presentation. Management of staff and follow-up are left to the nurse managers, and many post the roster report in a public place like a bulletin board in the break room, along with generating an email follow-up to individual staff who are below the target 98%. The informaticists further explained that corporate asks for totals for the facility and the goal is to be at 98% each month. After the data is generated and analyzed, the results are taken to the quarterly quality meetings to discuss the results further. During my interview with the informaticist, she was able to review my accuracy in meeting the benchmarks set forth by corporate. The data obtained is from September 1st through November 1st of 2018, which is the time which we have been at the facility for our clinic rotation this semester. So as you can see by the data, the facility is at 99% for scanning the patient's armband and 98% for scanning the medications. When looking at my individual numbers, it's easy to see from the data that I am 100% for the armband scans, but only 95% for medication scans. This is 3% below the benchmark set forth by this facility. And I'm bringing this data forward today because as my clinic group, you also share the responsibility for not meeting these numbers. So my goal today is that I want to make you aware of this data and to think about ways that we can improve this number moving forward in our final days of our clinic rotation. So when I met with the informaticist, these numbers were not a surprise to me. The facility followed the steps I listed previously in alerting me of my non-compliance on this issue. And as I'm not a staff member of this facility, my contact person is our facility educator. And she's the person who reaches out to me to discuss my numbers and counsel on how to go about improving them. So one of the important points in this process is the principle of individual accountability without provoking shame. So I can only speak for myself on this matter, but I feel comfortable with this individual, which can open the way towards productive conversations, and that's exactly what we were able to do. So when we sat down and we looked at my numbers, we were able to pull up each individual patient in which a workaround was obtained or where I entered an override, and we were able to look at it together and discuss the barriers as to what created that override. And that's the whole point of doing this, is that you have that open communication so that we can solve the problem together without assigning blame. So as I said earlier, when we're speaking with the facility educator, it is important to discuss the barriers in barcode administration. So after reviewing the overrides in the system, we were able to quickly discover the barrier to reaching the 98% benchmark. Each medication that received an override was on a medication that was pre-mixed in the pharmacy. So in the HMS system, the medication and the fluid it is mixed in both need a barcode scan. When pharmacy premixes a medication, the department generates a label and affixes it to the IV solution. The HMS system recognizes the label of the medication, but it still requires a scan for the normal saline in which it is mixed. So here is where the problem actually occurs. I explained to the facility educator that the labels are placed on the IV bag over the writing and the barcode. In order to scan the barcode, the nurse must remove the label. So you have an option here. You can destroy or ruin the integrity of the label, which is what actually happens most of the time, or you can do as I do and enter an override for the normal saline to preserve the integrity of the label. We were then able to brainstorm to find a solution so no one would have to override this again. She was able to involve the pharmacy director in this discussion. It was recommended that pharmacy place their labels on the other side of the bag so the nursing staff could avoid an override for the solution. Another common override that occurred hospital-wide was among the tablets with pharmacy-generated labels. Several nurses had complained their tablets were not scanning. Upon further investigation, the stickers utilized by pharmacy were too glossy and the barcode scanner was unable to read them. Since then, pharmacy has switched labels for their tablets and there's been minimal overrides since. Having a goal of improved barcode med administration compliance can allow the nurse managers to stress the quality improvement and safety nature of the barcode med administration report to nurses, effectively aligning the organization's interests with those of the nursing staff. And this alignment can be a powerful tool for building trust and constructive dialogue. So the entire facility is currently at 99% for scanning the patients and 98% for scanning the medications. Upon looking at these numbers, the hospital is doing great in terms of meeting their benchmark. But it makes me ask, are these numbers accurate? Or are the numbers false because of workarounds that we've encountered? So since the conversation with the nursing educator for the facility, the staff has let me in on some of their secrets to avoid getting dinged for overrides. And some of the workarounds include manually typing the order number of the medication form, for the MIR to trick the system into thinking it was scanned. Some nurses use another IV solution bag to scan, so not to damage the label printed by pharmacy. Some nurses keep stickers of each patient on their workstation on wheels to avoid waking a patient when scanning their armband. And some nurses pull all their patients' medications at once to save time of returning to the Pyxis between patients. So basically, they're carrying 5 to 6 patients' medications at once. Now, you don't have to answer me, but I want you to think about if you have seen some of these workarounds while you've been in clinic. Did you think it was wrong, or was it just part of the job of being a nurse? And these are things that you need to think about. Was this just a typical day for the nurse and that's just part of it? Or did you see what they were doing and think of it as wrong, but because they weren't hurting anyone, you didn't say anything? So just some things to think about. Like I said, you don't have to answer me right here. So based on these conversations and actually witnessing some of these workarounds done, I can probably determine that this data isn't 100% accurate. The current policy regarding a medication that won't scan is to notify a pharmacy of the medication and wait to dispense it until the pharmacy can send a replacement. So waiting on pharmacy can result in administering a medication that is late, which is incidentally another violation of policy. Many of the staff have verbalized that we know the medication is correct and it is the correct patient, so overriding a med here and there keeps me out of trouble with administration and the meds are still delivered on time. So again, I want you to think about this. Do you think the staff has a valid point here? And if your job is on the line, is it ethical to override the system to keep the numbers at or above the benchmark? And this is something that we have to consider when you're looking at these numbers. Another thing to think about is that technology can also impact these numbers. Every patient room has a computer with a barcode scanner attached to it. However, you guys have seen while we've been at clinic that most of the staff utilize those workstations on wheels because of convenience. If the computers in the rooms haven't been utilized in a while, you have witnessed how slow they can be. It takes several minutes to pull up the screen, and the nurse and the patient get impatient. Sometimes the connections are slow and the scanners can get disconnected from the computer tower. These technology hiccups can lead to inaccurate numbers due to faulty scanning. And therefore it's important to let the staff know when the computer isn't working so IT and maintenance can work together to troubleshoot the problem. Alright, so throughout our time today we've discussed a few things. We've talked about the significance of medication errors in healthcare. We've discussed the initiatives taken by healthcare to improve medication errors. That's the physician order entry, the Pyxis stations, and then barcode-assisted medications. We've talked about the process of how barcode-assisted medication administration works. We've also talked about some of the common workarounds that research has found, but we've also talked about workarounds that we've actually witnessed ourselves in clinic. And I was willing to show you my data and to show you how accurate or inaccurate my barcode assisted medication administration has been. So I think it's important to acknowledge that no single activity can offer a total solution for dealing with medication errors. And there is a combination of activities that have been proposed since To Err is Human was first published. So with adequate leadership, attention, and resources, improvements have been made and it will continue to do so. And it may be part of human nature to err, but it is also part of human nature to create solutions, find better alternatives, and to meet the challenges ahead. And this is something that I want to challenge you to do as you move forward as nurses, is to constantly be thinking and find better alternatives, but still keep patient safety in the background, okay, or in the forefront. Sorry, I don't want to say background. We want to keep it in the back of your mind, but in the forefront as we go forward. So I appreciate your attention in this presentation today, and the data that we reviewed is important to reflect on when you leave here. Many students don't understand that they are part of patient safety in the hospital setting while they're in the student role. So each time you prepare to pass medications to our patients in the hospital, I want you to ask yourself, are you following the safety guidelines set forth by this facility? What can you do to ensure that you are compliant with the benchmarks set forth by this facility? How will you respond when you witness these workarounds? So in a few short months, you're going to be the RN at the bedside. So how are you going to apply what you learned here today to that practice then? So this is just some food for thought as you move forward. So please feel free to ask me any questions after this presentation. I'm available in person, by phone, or email to discuss any concerns or questions that you have. And again, I want to thank you for coming today.